respected teachers and dear colleagues. Myself, Dr. Kajore Giri, would be the host of today's program. It is my immense pleasure to welcome you all in this beautiful Sunday morning for today's program arranged by the Women in Nephrology Telangana State Chapter of World Kidney Day program. Firstly, I would like to thank the experts for taking their precious time out for attending the program. And secondly, I would also like to thank our audiences to join this. Before we begin our today's session, I would please allow me to introduce to today's theme, which is Kidney Health for All, Preparedness of the Unexpected in Supporting the Vulnerable. I would request the audience to post their questions in the chat box. Our session will first initiate with a welcome address, followed by presidential address, followed by 2 seminar topics, and lastly, an exciting panel discussion. Now, I would like to invite Dr. Priyadashini John, consultant nephrologist in AIG Hospitals, Hyderabad, to start with the welcome address and introduction of today's theme.
Thank you, Dr. Kajri. On behalf of Women in Nephrology Telangana State Chapter, I extend a warm welcome to each one of you who have joined this World Kidney Day activity by WIN TS Chapter under the aegis of WIN India. Thank you for joining us. As we all know, chronic kidney disease is a major global health problem and is estimated to become the 5th highest contributor to years of life lost by the end of 2040. And more importantly, the morbidity and mortality of patients with chronic kidney disease are profoundly impacted, not just by the perspective from the patient's view, but also by the social determinants of health. So recently, we have seen many natural disasters as well as pandemics, which have caused enormous disruption in patients reaching to the diagnostic modalities or the treatment access. So it is not just limited to COVID-19, but many of the wars, that is Russia-Ukraine war in the recent times, and many of the natural disasters which we have seen recently, the Syria, the Turkey earthquake, and other man-made disasters like Beirut blast in Lebanon. And adding on to these, we have changing climate patterns with extreme weather events, which have been linked to increased risk of both development as well as progression of chronic kidney disease. So all these things add enormous burden to the low-income countries and low-middle-income countries. A global online survey of HD units conducted during the initial phase of the COVID-19 pandemic, which is conducted by ISN and DOPS study, it reported a significantly higher percentage of missed hemodialysis treatment in low-income countries, averaging to around 64% and 67% in low-middle-income groups, compared with the upper-middle-income countries, which is around 31%. So it is related to the limited access to the hemodialysis unit, as well as availability of the intensive care unit and mechanical ventilation availability to the chronic dialysis patients who are hospitalized. And recently, we have seen Ukraine war by the Russia, which has caused massive destruction of the infrastructure of the country, leading to the mass displacement of the population to the neighboring countries. All this caused disruption to continuous supply of water, electricity, and consumables, which are required in our hemodialysis as well as peritoneal dialysis. Traveling to another neighboring countries also builds up, also adds on to the cost to the patient. And also different policies by different countries will put a burden to the patient getting access to the hemodialysis. And also in the recently, we have seen that Hurricane Katrina, which occurred, it is reported that 44% of the patient living in the affected area missed at least one dialysis session, and almost 17% reported missing 3 or more dialysis sessions. In addition, there was also a 21% decline in the kidney transplant services in the year in that particular area a year later. So all these are one aspect, and adding to it the pollution, the climate change. The pollution is another significant determinant of kidney health, with exposure to the particles with a mass median aerodynamic diameter of less than 2.5 micrometer. It is associated with increased incidence of chronic kidney disease, as well as higher level of albuminuria, progression of kidney disease, and end-stage renal disease. So all these unfortunate series of events definitely serve as a catalyst and helps us to adopt to the variety of measures which we learned it when COVID-19 has occurred, which will help curb increase in the CKD prevalence, as well as help them sustain the availability of the essential and the life-saving kidney care modalities, and to protect for the vulnerable and prepare for the unexpected. So amidst all these things, the theme for this year 2023 is very much apt, that is preparing for the unexpectedness and caring for the vulnerable, caring for the vulnerables. So all these numerous threats faced by the global kidney community, it presents us all a unique opportunity to identify any particular solutions to the existing as well as impending challenges in the care and the delivery of the healthcare, and to protect our vulnerable group, especially in patients who are at risk for chronic kidney disease. With this, I end my talk over here, and I hand over this to Dr. Kajri.
Thank you, ma'am. That was a very short and crisp introduction of today's session. Following this, I would like to invite the presidential address, and that is to be given by Dr. Kiranmai Ismail, Professor, Department of Nephrology, Osmania Medical College and Hospital, and President of WIN India Telangana State Chapter.
Thank you, Kajri. Yeah. Good morning, all. Thank you for connecting to this special webinar where we celebrate the World Kidney Day. Thank you, Kajri. And thank you, Priya, for those sweet and short and crisp notes about the World Kidney Day and its importance of this year's program. So an estimated 850 million people worldwide are now have some form of kidney disease. All of us know CKD is the 11th leading cause of the death globally, and kidney disease is the 6th fastest growing cause of death. And it's also an important contributor to morbidity and mortality from other diseases like cardiovascular disease. In spite of this voluminous load, CKD is still considered a silent killer. And World Kidney Day aims at bridging this parity and create awareness in the society. It's a global campaign started in 2006, and this year, we all of us know the slogan, preparing for the unexpected, supporting the vulnerable. And this year, this campaign focuses on raising awareness about these disastrous events and their impact on people living with chronic kidney disease, whose access to appropriate diagnostic services, treatment, and care is hindered during such situations. So, to celebrate this World Kidney Day, we have two interesting lectures today and a very, very exciting and interesting panel discussion by our esteemed members. I welcome you all and thank you all for joining us today. Thank you.
Thank you, madam, for your lecture. I think we are all now adequately warmed up for today's session. We would like to move on to our next session or topic. I would like, which is on kidney ailments, protection of kidneys, and preparedness during natural disasters. I would like to invite our chairpersons, Dr. Manisha Sahai, Professor and Head, Department of Nephrology, Osmania Medical College and Hospital, Dr. Swarnalata Ji, Professor and Head, Department of Nephrology, NIMS Hospital, Hyderabad. I would request the chairpersons to introduce our speakers.
Thank you very much, Kajri. And thanks, Win, for this seminar today. And first of all, I would like to start by congratulating Women in Nephrology, WIN. It has grown over the last 1 year from no existence to existence across the globe, not only in India. And I congratulate the national team as well as the state chapters. And today is a testimony to that. We have so many seminars lined up where all state chapters are actively participating. So much about WIN. About World Kidney Day, we all know started in 2006, as our president, Dr. Kiranmai already highlighted. Each year we have a unique theme. And this year, again, the theme is very relevant. Post what we have faced during the last couple of years with COVID, we have seen it all. So the topic is very apt. And I feel what I realized is kidney patients are very different from other patients because kidney patients are dependent on dialysis, and the transplant patients also need to come to the hospital. Many of the other specialties can be managed online, but with kidneys, it's different. Dialysis is life-saving and you cannot just postpone it. So this topic is even more relevant. So with that, I would introduce the speaker for the first topic, young, dynamic Bhavya. She was a student of of Usmania and followed by her DM nephrology at Gandhi. And currently she is heading the department at Mamta Academy of Medical Sciences. So over to you, Bhavya, for your talk. We are looking forward to it. Thank you.
Thank you, ma'am, for your introductory words. So moving on to our topic today. So I will be speaking on, my slides are visible, right?
Yes, Bhavya.
Yes, visible.
Go ahead.
No stop, sir. No, no, in my stop. Oh, yeah, yeah. They said you should not use it for more than 7 days.
So I'm and preparedness during natural disasters. So outline of my presentation, I'm going to speak on disasters, the kidney ailments which are associated with the disasters, the crush-related AKI, the nuclear disaster, the floods, and how we should train our patients, how we should train our dialysis unit, and how as a nephrology community we should come together to face these disasters and disaster response, and a word on ISN, Renal Disaster Relief Task Force. So as we know, we have natural disaster and man-made disasters. So the natural disasters, we have seen the recent Syria and Turkey earthquake, floods and storms, drought and famine, and nuclear accidents from any nuclear power plant mishaps. And man-made disasters, we have wars, and sometimes we are anticipating nuclear weapon usage also, global warming and mining accidents. My emphasis on this talk would be mainly with regards to crush-related AKI and our preparedness. So the kidney ailments associated with these disasters are earthquake. We can see earthquake, war, and nuclear weapon usage. We see crush injuries, hemorrhagic shocks, dehydration, radiation nephritis in case the patient survives, floods, tsunamis, cyclones, and hurricanes, and which can cause diarrhea, vector-borne diseases, malaria, leptospira. And all these disasters are known to cause post-traumatic stress disorder and effect on mental health, which is poorly addressed. So if we see the spectrum of AKI after any natural disasters, we see in the mainly crush syndromes that is seen in earthquakes, wars, and other destructive disasters. And that's because of hypovolemia and myoglobinuria. And other AKIs we see are in pre-renal, we see because of wars, earthquakes, because of massive bleeding, post-renal, because of the pelvic traumas causing outlet obstructions, intrinsic renal because of ischemia and nephrotoxic ATN usage. My further talk would be emphasis on crush injuries. So in crush related AKI, the incidence is around 2 to 5% of all the patients, and out of which 30 to 50% are from traumatic rhabdomyolysis. It can be a mild presentation to a severe presentation, and depends upon the amount of muscle damage which has occurred. And it is aggravated by pre-renal causes because the patient is trapped inside the rubble and there is lack of access to water. There can be a vascular trauma, and there is a decompression at muscle injury site with third space loss. And this crush injuries can also be because of intrinsic renal, secondary to rhabdomyolysis, release of the muscle pigment, ischemic AKI because of the vascular trauma, severing and renal artery, which is normally catastrophic, nephrotoxic AKI, cardiac dysfunction, and sepsis. Post-renal is because of pelvic traumas. And how do we diagnose these cases? We have a suspicion if the patient has dark colored urine with nil RBC and a positive test by benzidine, and if we are having a pigmented granular cast, elevated CPK, some studies says that more than 16,000 high risk of developing AKI and renal failure. And biochemical abnormalities in the patients who develop AKI, we see that patients with hyperkalemia more than 6, hypophosphatemia more than 8, and having hypocalcemia less than 8, there is increased risk of developing AKI. So how do we prevent this AKI? Before extrication of the patient, I'm going to discuss further under this headings, before extrication, after extrication of the patient, use of bicarbonate, use of mannitol, and what are our urine output goals, how much fluid we should administer, and when we should correct the calcium deficiency, and is there any role for loop diuretics. So as you see, if first we should start this patient, can IV access secured before extrication? If yes, you should start IV fluids, normal saline is preferred because of easy bioavailability, and ringal lactate is a big no because it has potassium and we don't have any measures to measure the potassium on the site during a catastrophe. So start with 1 liter per hour and give it for 2 hours. If we can't secure an IV access, once the IV access is secure, start for 1 liter per hour. So after 2 hours, that is after administration of 2 liters, see that is the patient is out of that rubble. If the patient is removed out of the rubble, you can reduce the replacement fluid to 500 ml. If the patient is not out of the rubble, continue at the 1 liter. So the amount of fluid which you give depends upon the age of the patient and trauma pattern and ongoing losses. And monitor for 6 hours. And in the 6 hours, you can give up to 3 to 6 liters and see if the patient is anuric or not. And if the patient is anuric, decrease your fluid replacement. If the patient is not anuric, watch if he's having any old age or higher heart failure. If he's having these comorbidities, decrease your fluid replacement. If not, be liberal in your fluid replacement. Give around 6 liters per day. So start with 1 liter per hour for the first 2 hours and then slowly reduce and targeting around more than 6 liters per day. This is a preventive measure. A very early and adequate hydration decreases the risk of AKA. So before extrication, thus patients with rhabdomyolysis may require massive amounts of fluids up to max up to 20 liters. And in some earthquakes, they have in some studies, they have seen that the patients who are replaced around 20 liters on the day of the event which has occurred, there is less chances of needing a dialysis session than the individuals who have very less access to the fluid replacement. Similar replacement is also required in kids, 50 to 20 ml per kg per hour, and normal saline is a preferred fluid. So once the patient is removed out of the rubble, then if the patient is having a low chance of do a thorough examination and determine if the patient requires any surgical or medical intervention. If has low chances of survival, triage the patient, high chances, go ahead with your fluid replacement. So what's the role of the bicarbonate therapy? We know that bicarbonate has many advantages. It increases the urine pH. By increasing the urine pH, it decreases the precipitation of myoglobin and with Tom Hirschfeld proteins. It decreases the CAS formation, decreases the uric acid precipitation, and it corrects the metabolic acidosis and hyperkalemia. Myoglobin, after being released from the muscle, it releases the iron moiety, and this iron FT isoprostanes are known to cause renal vasoconstriction. Already there's having a hypovolemia, hypoperfusion, and you are additionally, because of the myoglobin, there is renal vasoconstriction, further aggravating the ischemia. So bicarbonate comes into picture, decreases this, and decreases the hypochloremic acidosis, which is caused by excess normal saline being administered. But what are the disadvantages with bicarb therapy? There is a calcium phosphate deposition which happens and which causes hypocalcemia. It also causes hypokalemia, which requires frequent monitoring. So in a situation like an earthquake where the resources are very dwindling and when the patient load is very high, it's difficult to monitor the case. So bicarbonate therapy is preferred to go for IV hydration and bicarbonate if the patient is in a setup, and if the earthquake or any war is in a limited area, then you can go for bicarb therapy. And there are 2 regimens available. You can use 1 liter isotonic saline plus 1 liter half normal saline plus 50 milligram equivalents of bicarb, or 2 liters of isotonic saline plus 1 liter of half normal saline and 50 milligram equivalents of bicarb. So out of these 2 regimens, see patient metabolic acidosis status and the fluid status. If the patient is hypovolemic, go with 2 liters of isotonic saline regimen. If the patient is in normovolemic state, go with 1 liter. And what is our target is always give around based on the urine output goal and volume status, and the amount should be administered is 500 ml per hour. After 24 hours, you should decrease the rate, but you should always, the rate should be still high than the 24 hours urine output. And the amount of bicarb which is given in 24 hours is around 200 to 300. And you need to monitor urine pH, you need to monitor blood pH, you need to monitor calcium, potassium, and bicarb levels. And you need to stop the bicarb therapy immediately when the urine pH is more than 6.5, blood pH is more than 7.5, and the bicarb level is going beyond 30. And if the patient is developing symptomatic hypocalcemia. And hypocalcemia, treat the patients only when it is symptomatic, because we know about rebound hypercalcemia which occurs in the recovery phase. So the next question comes is mannitol. Does mannitol has any role in pressure-related AKs for our nephrologists? So the role is controversial. We know the mechanism of action is not clear, and it is contraindicated in oligoanuric AKs. It is known to decrease the intertumoral heme pigment deposition and CAS formation. It helps in free radical scavenging and high CK levels. In patients with CPK levels more than 30,000, they have seen that mannitol with bicarb is beneficial. So how do we know that mannitol, can we give mannitol or not? Start a trial, give around 60 ml of 20% mannitol, which comes in a 100 ml bottle. Wait for 20 to 30 minutes and monitor the urine output in the next hour. If the urine output is less than 50 ml, discontinue mannitol. So our target urine output is always 200 to 300 ml per hour. So therapy, if the patient is having a good diuresis with mannitol, you can continue with the therapy and you should give it at the rate of 5 grams per hour. But with mannitol, always watch for volume overload, pulmonary edema, hyperkalemia, and even cerebral edema, hyperkalemia and hypernatremia. So how much volume we should administer? During and crush related AKI, the total volume administered should be around 500 ml per hour. That is 12 liters per day. We are targeting a urine output around 200 to 300 ml per hour. That is approximately 8 liters per day. And you need to replace 4 to 4.5 liters more than the total losses. And if the situation is very chaotic, you can go for less replacement fluids also. Loop diuretics, the loop diuretics appears like the diuretics decreases the sodium potassium 2 chloride channel in the most ischemic area, that is the loop of Henle. Though it appears that decreases ATP usage and it protects the tubules, it is having a controversial role because it causes hypovolemia, and we know that hypovolemia aggravates rhabdomyolysis related AKIs. What are unit output goals? So our target is 200 to 300 ml per hour to prevent the cast formation, and we need to catheterize all the patients unless there is a pelvis trauma. So and remove the catheter because the catheterizations are being done under aseptic conditions. If once the patient develops renal failure, established renal failure, remove the catheters, or if the patient is having complete renal recovery, remove the catheters. And IV fluids, physical examination, IV fluids, physical examination, and based on the biochemical parameters, you should go for IV fluids therapy, and duration is still disappearance of myoglobinuria. Hypocalcemia, correct only if the patient is symptomatic, and hyperkalemia can be present without AKI. So in disaster settings, they advise patients, all our dialysis patients need to stock up on this one zirconium silosylicate. If it's available in the Indian market, it is 10 grams is available in 78 rupees. It's better to stock it up and prevent oral dose can be given, SGSC or patiromal. So if those are not available, you can go for K-bind sachets also, but K-bind is acid with high risk. When SGSC is not available, then you can go for STS, polystearate. Okay, accelerate. Avoid ringer lactate solutions. Monitor potassium many times a day. If not possible, do ECGs, and point of care devices are very useful. But ECGs are sometimes we see hyperkalemia patients with normal ECG findings also. But in this disaster-stricken conditions, whatever procedures or ECG is definitely beneficial than doing nothing. My slides are stuck. 1 second, please. Yeah. So in the treatment of established AKI, there is no specific therapy for established AKI, and the routine indications for dialysis, that is volume overload, hyperkalemia, severe acidemia, and uremia. Those are the routine indications. There are no specific different indications to start a dialysis in these patients. And out of this dialysis, intermittent hemodialysis is preferred versus CRRT, because CRRT is a more logical, because the myoglobinuria is there, and there is the continuous release of potassium and uric acid from all this injured muscles, myoglobin from the injured muscles. But one machine will be trapped to dialysis patient. One machine will be trapped for the entire 24 hours. And in a disaster situation, we need to provide dialysis to many patients. So IHD, intermittent hemodialysis, is better, and you can cut short the dialysis sessions if and when required. And PD, if the patient is already on peritoneal dialysis, you can do it. But in AKI, and with abdominal traumas are not being properly evaluated, PD is not preferential in these patients. I'm sorry, actually, something is happening with my slides. My slides are getting stuck. Yeah.
You can present like this, Bhavya, if you have any issue. It's not a problem.
Ma'am, you can reshare, unshare and reshare once, ma'am. I think.
So nuclear disasters. Yeah, I'll try it. If it's not working, then I'll do that. Yeah, the dose at which the people close to nuclear plant war are exposed to die due to marrow suppression. Dose at which the patients close to the nuclear plant war are exposed to die because of marrow suppression and GI failure before the renal impairment even sets in. So if the patient survives, then the risk of renal radiation nephritis comes into picture. And as we know, cyclones, floods, and hurricanes, they are most common types of natural disasters affecting over 2 billion individuals globally from 1998 to 2007. And we see contaminated floodwaters hampering our dialysis units, water supply, and there is increased risk of vector-borne infections because we being a tropical country, and an increased risk of snake bite, AKS, injuries from falls, and loss of medications. So the next question comes, how prepared are we for these disasters? Are we really prepared for these disasters, and how we are supposed to mitigate these disasters? So when a disaster strikes, everyone thinks of response. Rather than response, preparation is very important. No one gives importance to the preparation, and expecting a response without preparation doesn't work out. So we should be prepared for the disasters, and we should train our patients. And as we should train our dialysis unit, we should train the nephrology community. And the preparedness should be in 3 phases. That is ready phase, set phase, and go phase. Ready phase should start around 30 to 90 days. That is 3 months prior to an expected disaster in case like cyclones or storms, which are expected based on the weather. For war or anything, preparedness doesn't come into picture, but being prepared makes us easy to negotiate the situation, navigate the situation. So patient preparedness. So how we should counsel our patients? 30 to 90 days before the disaster, we should counsel them regarding the importance of ID cards, and ask and the ID cards should have their blood group, allergies, their serology status, viral markers, and dialysis facility name, the contact number. And in case the dialysis facility has tie-up to another backup dialysis facility in view of any disaster, that also should be there in their ID card. And the patient should have all the papers with regards to their treatment charts, their insurance documents, their phone numbers, and attend the annual preparedness meetings. So we need to conduct the meetings, and we should make sure that the patients should attend the meetings. And 10 to 30 days before the disaster, the patients should back up on their medications. Transplant patients always should have a backup for at least minimum is 2 weeks. PD patient also minimum is 2 weeks. And they should identify a potential location for evacuation in case if there is on the faulty earth line causing earthquakes area or in a flood prone area, they should be prepared for a prospective area for evacuation. 1 to 10 days before disaster, they should identify a backup clinic, and they should notify the backup clinic. If there are calls coming from the backup clinic, the patient should answer the calls, and they should be prepared for evacuation. So next comes the dialysis unit. This is the summary. So if the patients be ready with ID cards, insurance documents, attend the meetings, and update their phone numbers regularly, which they don't do. And 10 to 30 days, stock up on the medicines, the PD supplies, and identify the evacuation locations. 1 to 10 days, answer the calls and prepare for evacuation. So how, as a dialysis unit, how we need to train our technicians, our staff, and ourselves. So 30 to 90 days before the disaster, we should issue the patient ID cards. We should conduct the annual preparedness meetings. We should conduct contingency plans for staff shortage and obtain generators, and always see that the generators are above ground level. Never trust the generators which are in a basement or -1 levels. And 10 to 30 days before disaster, test the generators, see that it has adequate fuel supply, and enhance the capacity in case our dialysis unit is ready to accept the patients from other areas with us that is stricken by the disaster. And 1 to 10 days before the disaster, we should review how much staff is available with us and coordinate with the emergency response team and take an account of patient and staff, what is the count of the patient and staff, and facilitate the patient treatment at the backup center in case we are sending our patients to another center for dialysis. So as a dialysis unit, as our team, we should issue the patient ID cards, we should conduct the preparedness meetings, we should obtain the generators, we should maintain contingency plans for staff shortage. And within 10 to 30 days, we should test the generators, we should have adequate fuel supply, and we should enhance the capacity of our staff. And after 1 to 10 days, track and account if the patients and staff, they are in a safe location when the disaster strikes, and coordinate with the response teams and facilitate the treatment at a backup center. So during the disaster, the main issue comes with the water. So if there is any impairment in the water supply to our dialysis unit, we can use, if there is a well, the water can be used, or you can use from a tanker also. And if the only deionization unit is available, use a submicron or endotoxin microfilter. And other thing is, the staff should always have a mock disaster drill, so they will be prepared. And staff should know the proper measures how to close the patient when the disaster occurs. And the patients should stock upon potassium binding resins, as I told you in the previous slides. So preparedness by the nephrology community at the higher level. At the higher level, at the national level, we should develop a seasonal to sub-seasonal kidney health threats and generate a long-range kidney health threats forecast based on the seasonal weather forecast, and they need to train the volunteers. And 10 to 30 days, they should coordinate plans with the central and state agencies regarding resources, and they should allocate the resources. 1 to 10 days before the disaster, generate the short-range kidney health threats forecast, activate the volunteers and evacuation plans, establish separate hotlines for the patients and clinicians, and you need to manage the hotlines as well. So, as a higher level nephrology community, national level, they need to identify the volunteers and train the volunteers. They need to maintain a register for the seasonal and sub-seasonal kidney health threats. They need to identify with the weather forecast and coordinate a plan with the state and central governments, allocate the resources, activate these volunteers, and develop an evacuation plan and manage the hotlines. So what is the disaster response? So now that we are prepared, we should respond to the during a disaster. So management during a disaster in a dialysis unit, clamp and cap procedure to remove the patients from the hemodialysis. Cutting lines or catheters is not recommended. If there is no immediate danger and the power is lost, hand crank the blood pump, return the blood to the patient, then clamp and cap lines. And evacuation of the patients and the staff to the designated safe area should be done, and do a head count after being evacuated. And if the situation assessment must be conducted early to assess the patient and staff, injuries and the dialysis unit damage should be seen, and if the building is usable for dialysis or not. If the assessment if the hemodialysis can continue in the facility or evacuation to the other predetermined dialysis sites need to occur. You need to evaluate that. For massive disasters, we have the support from ISN, International Society of Nephrology, Renal Disaster Relief Task Force. This is established in 1988, and it has done a great role in all these earthquakes by providing the personnel and supplying the patch roamers, supplying the resources like dialysis, tubings, and everything. But the thing is, this is available in our ISN site, but there is a malware which is being popped up when we are trying to access this. I think Manisha madam can help us with this, so to access this. There was some malware with that. So when the disaster strikes, we need to have a planning is important than being looking for the response. So always be planned so that the response will be more smooth. So this is a famous saying plans are nothing, planning is everything. So I would end my talk saying that always be prepared for the disaster. So disasters are inevitable, and we being prepared makes us easy to navigate such worst circumstances in our life. Thank you.
Thank you, Bhavya. That was a very interesting coverage on the topic. So firstly, I would like to appreciate our women in nephrology India for successfully conducting a second, the WKD program, like a marathon. Today we have marathon events, and then, all the chapters are being covered today. I think it's the occasion where we should, pat our backs. So we should all celebrate it. And coming to the topic, I think it's very relevant topic. Now we have seen, as Bhavya has emphasized, we are all seeing, natural calamities and man-made disasters. We have seen recently, come across the COVID. Now we have the earthquakes, we have the war going on. So I think it is very pertinent for all of us to get prepared. And she has very elaborately covered the individual kidney diseases which we can come across in this disaster, and how we should able to prepare ourselves as an individual, like a doctor or an association, or the countries and the policy makers. She has very well emphasized. I really appreciate Bhavya for covering all the important aspects of it. And what I want to add on that, it is probably a right time for all of us to also, as in Hyderabad Nephrology Forum, or as women, or as a an association, we should also try to start working on it. So because we see the disaster, whenever we go out, we see a disaster, a vehicle standing there. But I know how far the mock drills are happening, and really these, the disaster management teams are really able to, cater to, or come in right time to help whatever disaster is happening in terms of supplying the consumables, or the manpower, or whatever you have said. They have to be checked in regular basis for the functionality and the adequacy of the equipments, or the consumables, or the manpower. So I think that we really have to start the program, not just discussing and ending there, So this is probably a beginning of it, and all of us has to think about it and start our own activities at various level. So thank you, Bhavya, once again for a wonderful.
Thank you, ma'am.
Thank you, the winner.
Thank you, ma'am. Thank you.
Telangana chapter.
Thank you, ma'am.
Thanks, Bhavya. Congratulations from my side as well. And I fully echo what Dr. Swarnalata said. And I think HNF can think and WIN may think that creating a disaster cell or maybe a disaster response team or something. So I mean, having the webinar itself is the seed to starting such new activities. Thank you. Wonderful talk.
Over to the organizers.
Thank you, ma'am. Thank you, ma'am.
Thank you, madam. That was a very excellent talk. I think she very lucidly elaborated how, in a timeline approach, how we can be prepared, better prepared for any natural disasters like floods, cyclones, or any artificial man-made disasters like war. She also lucidly gave us a timeline that what we should do in 30 to 90 days before disaster, in 10 to 30 days, or 1 to 10 days before disaster. I think the key home messages will be preparedness of an ID card, preparedment of a backup medication, backup clinic, backup.
Yeah,
Yes,
just one
yes,
point.
ma'am, sure.
Now that like summer is coming, there is some, the heat wave is expected. Nino, I think we should all be prepared for that. Immediate preparation for the next disaster.
Yes, ma'am. That was a input. So I think madam also stressed on our preparedness. With this enthusiasm of the session going on, I would like to start our next session, that is a talk which is screening for CKD and caring for the vulnerable. That is from AKI. We now move on to the chronic kidney disease and the already vulnerable population in our community. For this talk, I would like to invite our respected chairpersons, Dr. Manjusha Yadla, Professor and Head, Department of Nephrology, Gandhi Medical College, Dr. Rama Engati, Assistant Professor, Department of Nephrology, Osmania Medical College and Hospital, and Dr. Rana Fatima, Assistant Professor, Department of Nephrology in Pratima Medical College, Hospital, Karimnagar. Over to you, madam.
Thanks, Dr. Kaji. And that was a wonderful discussion that has been going over the last hour to 45 minutes. Just to add on to that, yes, the government of Telangana has taken an initiative for the protection and for saving the lives as well. This is from the government of Telangana. It has started a massive CPR program for everybody, training everyone, the public as well. This was a recent initiative by GMR in collaboration with the government of Telangana. So that's again for gearing up to salvage the lives in a similar corroborative lines. So moving on, thank you for inviting me to be the chairperson for the subsequent session. We have with us Dr. Deepthi Ainavali, who is going to speak to us on the another important area, that's the chronic kidney disease. She is a consultant nephrologist from ESI Hospital, Hyderabad. So the floor is yours, Deepthi. We are ready to hear and learn from you with respect to the CKD and protecting the vulnerable, which is in fact one of the themes of the WKD 2023. Over to you, Dr. Deepthi. Deepthi, can you just start sharing your screen? I think we missed you in the tech check, but nevertheless, I think you can just start sharing your screen and see whether the slides are visible or not. Yeah.
Are my slides visible, ma'am?
Yes. Please put in slideshow mode, Deepthi. Perfect. Yeah. You can start. Please go ahead.
Good morning, everyone. Thank you for giving me this opportunity. My talk is on screening for CKD and caring for the vulnerable. It goes with the following headings: incidence of CKD and its burden, screening of CKD, vulnerable groups, and summary. So the burden of CKD has been increasing worldwide, affecting more than 10% of the general population worldwide. So the CKD is mostly affecting the lower and middle income countries. It is one of the non-communicable diseases that had shown a rapid rise in the past 2 decades, and it is a complication of other non-communicable diseases like diabetes and hypertension and obesity. So pulling of the 33 population studies into the prevalence of CKD is around 10.4% in men and 11.8% in women, affecting almost 1 in 10 persons. The current number of CKD people are 8,436 million in 2017. The global all-age mortality of attributed to CKD has been increased to 41.5% from 1990 to 2017. And the CKD being the cause of years of life lost, it is in the 19th place in 2013, and in 2016 the rise has increased to 13th place, then 12th place, and it is expected to be in the 5th place by coming 2040. So it is mostly the large burden is in the lower and middle income countries, as I have said, and in high income countries, mainly the Singapore, Greece, and Israel are mainly affected. So early detection of CKD can cut making preventive strategies can curtail this morbidity and mortality related to the CKD. So an ISN embarked a project with including population-based studies and targeted population screening studies. Almost 7,000 studies were included from global to form a framework to the nephrologists and health system, informing a strategy for risk stratification and treatment in these people. So the population-based screening methods had detected CKD. Early CKD identification was done, but in targeted population, greater CKD prevalence was seen, and with follow-up along with interventions like lifestyle modifications and pharmacotherapy were initiated in targeted population studies. So targeted population studies are better than population-based screening methods. So there were no clear consensus on this early identification and intervention program. So in 2019, KDIGO had held a conferences conference on early identification and intervention in CKD with the goal of knowing populations for screening, measurement for early CKD, interventions in CKD, and health system and economic factors. So whom to screen? Mainly the persons with risk factors, hypertension, diabetes, or cardiovascular disease are the first priority, and other high risk individuals with genetic comorbidities, environmental exposures, or other metabolic comorbidities are seen, like diabetes, hypertension, hyperlipidemia, obesity, autoimmune diseases, SLE, and age greater than 60 years. All these population has to be screened for the CKD. Which method to use? eGFR and albuminuria, both dual assessment has to be done, and accurate GFR estimation includes both creatinine and cystatin measurements for initial diagnosis and staging. So these including all these three is affordable in high income settings. So initial screening creatinine based eGFR can be done in our population. Later cystatin based measurements has to be done, mainly in older age patients where the CKD is overestimated. With this formula, cystatin and creatinine based measurements has to be taken. So interventions in CKD, this is secondary prevention, like after detecting CKD, lifestyle modification, smoking cessation, RAS inhibition, drug therapy, all this has to be intervened in this after detection of CKD. So when GFR is less than 60, patient patient has to be guardedly given the dose medications according to the GFR and reduce the risk of AKI from volume depletion. The use of both AC inhibitors, ARBs should be avoided, and contrast associated AKI can be prevented by using low dose of isoosmolar contrast and giving isotonic saline pre and post contrast. When eGFR is less than 45 to 60, avoiding NSAIDs is required. 30 to 45, avoid NSAIDs and dose modification of metformin. When it is less than 30, NSAIDs, bisphosphonates, metformin, and avoiding access lines, venous lines for access preservation has to be done. So to retard the CKD progression, blood pressure has to be controlled with AC inhibitors or ARBs along with diuretics, and dietary salt sodium has to be less than 2 grams per day. And diabetics HbA1c control should be 6.5 to 8%. And for those with eGFR greater than 30, SGLT2 inhibitors and metformin can be used. If not achieved, other drugs can be added. So CKD complications like anemia, HbA when hemoglobin is less than 10, erythropoietin stimulating agents has to be added. Acidosis correction has to be done from CKD stage 3. CKD MBD to assess calcium and phosphorus, vitamin D, and IPTH monthly, and supplement these vitamin D deficiency has to be done. Patient has to be vaccinated for influenza, pneumococcal, and hepatitis B, and screened for hepatitis C. To prevent cardiovascular disease in these patients, blood pressure has to be in control. Lipid lowering therapy has to be initiated early. Means if the age is greater than 50 years or lower is with other risk factors for CAD like diabetes mellitus, prior stroke, or high CVD risk score. So low dose aspirin has to be started in these patients. These all these interventions can be done at the physician level with the proper education to them. And nephrologist intervention is needed when there is a rapid decline in eGFR or a consistent significant albuminuria, progression of CKD, and glomerular presence of dysmorphic RBC and suspicion of glomerular diseases, and refractory hypertension, hyperkalemia, and nephrolithiasis, and hereditary kidney diseases. So, health system and economic factors. So CKD screening and treatment requires multi-stakeholder implementation strategies. Financial and non-financial incentives need to be aligned for this screening, risk stratification, and treatment. CKD screening is likely to be cost-effective, and the approaches may differ in lower middle income countries and other higher income countries. So this is a conceptual framework. Initial population has to be screened. Then when diagnosis is confirmed, risk stratification and treatment has to be initiated. If diagnosis is not confirmed, they have to be screened annually. So primary and secondary prevention occurs when the kidney is in normal level. So when the damage is initiated, CKD to retard the progression, tertiary prevention measures has to be started. So primary prevention requires healthy lifestyle measures, and to prevent a secondary prevention, diabetes and hypertension has to be addressed, and other risk factors has to be addressed. So now, what do we know about CKD in India? So the first ISN CKD registry was started in 2005. This is the first report by Rajput sir in 2012. With diabetic nephropathy being the leading cause of CKD, followed by CKD of unknown etiology, then CGN and hypertensive nephrosclerosis. There were some geographic variations in this pool, and CKD of unknown etiology, mainly patients are of younger age and poorer socioeconomic status and presented with advanced CKD. Later, this is the SEEK screening and early evaluation study, which included the cohort from the academic and private medical centers. Almost 5,000 patients were included, where the age-adjusted incident rate in India was found to be 229 per million population, and almost greater than 1 lakh patients are entering the renal replacement programs annually in India. So using the CKD-EPI equation, the prevalence in India was 16.4%, and with the MDRT equation, it was 17%. Later, this is Indian CKD study, where the baseline characteristics, risk factors of a large cohort from the public sector hospitals were recruited. This is a publicly funded large cohort, wherein diabetic kidney disease, CAN, and CKDU were the leading causes. So coming to the higher the screening population, CKDU, this is a upcoming topic from the past 2 decades, wherein the patients from a particularly rural population and the poor socioeconomic status are coming without known risk factors like diabetes or hypertension. Mainly in India, the hotspots were these, where Prakasham, Srikakulam in Andhra Pradesh, Chhattisgarh, and Telangana, Nalgonda and Adilabad in Telangana, and other states involved are Chhattisgarh, Goa, Gujarat, Karnataka, Kerala, Maharashtra. Mainly South India was mostly affected, where where agricultural farming is common. So coming to pathogenesis of this CKDU, and the main factors were volume depletion, heat stress nephropathy, working in hot temperatures, increased physical activity in these patients, resulting in the loss of water and hyperosmolar condition, which is activating the posterior pituitary and increased uric acid formation by the and activating the inflammatory oxidative stress system, resulting in AKI followed by chronic renal disease. Apart from these predisposing genetic factors, use of pesticides, heavy metals, contaminated water, other tropical infections, use of NSAIDs and antibiotics in this pool of patients is increasing the incidence of AKI followed by chronic interstitial inflammation and glomerular involvement. So the several hypotheses were proposed for the CKDU, like contaminated water, air pollution, heavy metals, insecticides, heat stress, everything. But nothing has been nothing had robust evidence for causal relationship in this. So these patients are will be usually presenting with asthenia, low-grade fever, rhabdomyolysis. And then after progressing to renal dysfunction, they may have dysuria, nocturia, lumbar pain, for which they will be taking NSAIDs and antibiotics. Electrolyte disturbances like hyponatremia, hypokalemia, hypomagnesemia, and hyperuricemia are seen. And urine abnormalities, non-nephrotic range proteinuria, leukocyturia, isostheneria, and urate crystals will be seen. Coming to histopathology, in the early stages, they will be having acute inflammation with the T lymphocytes and monocytes at the corticomedullary junction. Later, it progresses to global sclerosis, thickening of Bowman's capsule, or periglomerular fibrosis, resulting in chronic glomerular ischemia. IF is usually negative in these patients. So what we need to do in this cohort? We need to avoid heat stress, prolonged heat exposure by decreasing the working hours or decreasing the working in the hot temperatures, timing in the hot temperatures. Nephrotoxins like NSAIDs and antibiotics should be avoided. Education should be given to these cohort about this. And use of agricultural insecticides, so there should be a government strategies regarding the level of insecticide should be used. So after CKD detection, there is, apart from CKD management, these patients should also be supplemented with potassium, adequate water, and if still hypokalemia is there, potassium sparing diuretics has to be added. Though alkalosis is seen in the picture, acidosis correction is required in these patients. Hyperuricemia with hyperuricemia has also been addressed. Anyway, for prevention is undoubtedly the best treatment in this cohort. So in the same way, in our country, tropical infections affecting this agricultural community and farmers is also a main thing where the CKD is progressing in these patients due to malaria and leptospirosis. Dengue, scrub typhus, yellow fever, these were addressed to be causing AKI, but causal relationship with CKD is still yet known. Malaria and leptospirosis are evidence to be causing CKD. So leptospira is a re-emerging genetic disease mainly in slaughter workers and garbage collectors, sewer helpers, wherein these patients will be having imminent AKI or asymptomatic leptospiral infection, which may progress to CA and CKD, like in CKD. So these tropical infection patients, means malaria patient, all these patients should be screened at regular intervals after AKI has been treated. So genetic association, along with comorbid conditions and unhealthy lifestyles, genetics APOL1 gene and myosin heavy chain 9 gene are associated with CKD diseases, and mitochondrial stress damage also results in CKD. So specific genes which can lead to specific clinical actions are mainly Fabry's, primary hyperoxaluria, cystinosis, tubulopathies, where specific disease modifying therapies can be initiated. And for prolonged avoidance of prolonged immunosuppressive therapies, like in Alperts, we can do genetic testing. And to know the recurrence after kidney renal transplantation, atypical HUS and primary hyperoxaluria, APRT also has to be can be done for genetic testing, and conditions in which genetic testing is relevant for reproductive counseling, they can be advised regarding the prenatal and pre-implantation diagnosis. So environmental pollution, mainly heavy metals, air pollution, and non-heavy metals. So all these also cause CKD. Though the levels are not exactly measured, lead, mercury, cadmium, uranium, all can cause nephrolithiasis followed by CKD. Air pollution is mainly particulate matter less than 10 micrometers and less than 2.5, including nitrate sulfates. All these have inverse relation with the CKD, is it EGFR. So phthalates, melamine, BPA, all these are used in the daily household can cause nephrolithiasis and CKD. Insecticides, organochlorine pesticides mainly have can have proximal injury followed by CKD. Aristolochic acid, as we all know, it can cause Balkan endemic nephropathy. So regarding this, we need regulatory strategies for the control of pollution and exposure to environmental health risks. So diabetes and CKD, who and when to screen? Type 2 diabetics, mainly immediately after diagnosis, we have to screen for CKD, and in type 1 diabetics, every year, after 5 years of diagnosis has to be screened. They have to screen for the albuminuria and EGFR. If there is a positive result, cystatin C and creatinine measurement of EGFR has to be done. When there is persistent abnormalities, we can label them as CKD. So albuminuria greater than ACR ratio greater than or equal to 30 mg per gram, or persistent EGFR less than 60 ml per minute per 1.73 meter square, or other evidence of kidney damage, we can label them as CKD. So initial lifestyle therapies, healthy exercise, nutrition, weight loss has to be advised. First line therapy, SGLT2 inhibitors or metformin has to be added until EGFR is 30. Additional drug therapies like GLP-1 receptor agonists, DPP-4 inhibitors, sulfonylurea, sulfaglucosidase inhibitors, all can be added to these above treatment. And insulin, insulin also can be given at all stages of CKD. So renal disorder, this is also a high risk group where pregnancy and CKD. So preeclampsia health syndrome can occur in second or third trimester or in postpartum, which can result in AKI, follow if not promptly treated, progress to CKD. Bladder outlet obstruction, it can occur due to physiological changes in the urinary tract and ureter. But multiple pregnancies can also cause obstructive symptoms. So TTP, atypical HUS, if not treated early with plasma exchange or eculizumab, they can progress to CKD. Urosepsis is common in pregnancies where antibiotics has to be used if needed. And lupus nephritis flare is expected in pregnancy, and HCQs are continued in these patients. And flare can cause AKI, glomerular disease, followed by CKD. So gestational hypertension and gestational diabetes in pregnancy has to be monitored, and they have to be followed after the resolution of hypertension and diabetes yearly, so that they because they'll be having recurrence of hypertension and diabetes followed by nephropathy in these patients. So CKD and pregnancy means pregnancy in CKD patient it is very risk, means less than 1.4 and 1.4 to 2.9 we can advise to go for pregnancy, but greater than 3 creatinine level, the maternal and fetal complications are very high, and chances of pregnancy are very low. So there should be preconceptual counseling regarding preeclampsia, growth restriction, preterm delivery, low birth weight, loss of maternal renal function before going to conception. And when the patient is on immunosuppression, mycophenolate has to be stopped at least 6 weeks prior to the conception, and other medications has to be reviewed. And my MMF can be replaced with azathioprine. The BP should be optimized in this patient before going to conception. AC inhibitors can be continued until conception if proteinuric, and they should be annually checked for pregnancy. Sorry, monthly checked for pregnancy. And lupus nephritis should be quiescent at least for 6 months in these patients. And when patient is post-renal transplant, MMF should be continued at least for 1 year. Later can be converted to azathioprine and observed. Then after 2 years of transplantation, can go ahead with conception. So folic acid supplementation should be given before pregnancy. Rubella immunity and smoking cessation and alcohol cessation has to be advised. So patients with pregnancy, There should be a plan for the CKD pregnancies, means it should involve both obstetrician and nephrologist. They should be monitored for blood pressure, serum creatinine, and urine PCR. EGFR cannot be used in these patients as it can underestimate the renal function. So growth scans has to be done every 4 weeks after 28 weeks of gestation, and they should be screened for trisomies. And complications of CKD like they should be targeted BP should be less than 140/90. Erythropoietin has to be initiated. Low molecular weight heparin prophylaxis is advised if proteinuric means greater than 250 milligrams per millimole. Vitamin D deficiency should be supplemented. And if patient is on dialysis, at least greater than 36 hours per week of dialysis should be achieved. And if there is any, if the patient should be initiated on HD, there should be low threshold because of the urea having phytotoxicity. Greater than 20 millimoles per DL has to be initiated on HD. So renal transplant patients, maintaining CNI levels is very important. Aspirin can be aspirin should be started in first trimester to prevent preeclampsia. So caring for the elderly. So elderly itself is means age greater than 60 years is itself a risk factor for CKD. Usually EGFR formulas are having age. So most of the patients will be classified as stage 3 CKD. Though many will be having normal serum creatinine because of low muscle mass, no albuminuria, but EGFR range between 50 to 60 ml. So for every decade above age 40 years, GFR declines by 10 ml. Physiological aging means loss of nephron number, glomerular sclerosis, tubulointerstitial fibrosis. All these result in hyperfiltration and increased glomerular hypertension, resulting in decreased EGFR. Along with physiological aging, pathological comorbidities, hypertension, diabetes, heart failure, obstructive pulmonary disease, and use of polypharmacy drugs, nephrotoxic drugs, NSAID antibiotics, iodinated contrast, all these contribute to AKI followed by CKD in these patients. So we need to target the risk factor control in these patients, like blood pressure control and diabetes control. Nephrotoxin should be avoided. ESA should be initiated with hemoglobin less than 10, and iron deficiency should be supplemented with oral iron. Acidosis can be corrected even from CKD stage 2 in elderly. So the timing of initiation of that means in the stage 4 CKD, patient should be counseled regarding the alternatives of renal replacement therapy. If the patient is okay for hemodialysis, so the access creation has to be done with fistula first initiative. Vitamin D bone disease has to be monitored and supplemented. Renal replacement therapy in the elderly, it is a little tricky, means there is no consensus. Even if EGFR is less than 15, if the patient is not symptomatic, we can hold HD. But if EGFR is less than 7 ml in these patients, we need to start dialysis. And if the patient is symptomatic and EGFR is less than 15, renal replacement therapy has to be initiated. So finally, summarizing all these things, economic stability, political legal factors, socio-economic factors, healthcare provision, education, all these factors can curtail this CKD morbidity and mortality. And screening has to be a program initiated from the government. So political legal factors include government policies for dialysis and transplantation already been initiated in our state. So law enforcement against organic trading should be done. And in the environmental, mainly air pollution, giving a good clean water, good sanitation, risk of infectious diseases has to be decreased. Health education regarding healthy lifestyles, healthcare seeking, and when to take the healthcare, and programs for screening and monitoring has to be educated to the people. And social and community context, social discrimination should be avoided, and community level resources has to be improved. Economic stability like job security and medical care affordability should be improved in our country. Thank you.
Thank you, Deepthi. That was wonderful, actually. I mean, it was an amazing talk. I think you've covered all the aspects of, the CKD. I think your video is paused. Yeah. So anyway, just to add a few points before I hand over to the co-chairs of this session, you have spoken at length about the ESKD care. So ESKD care is a complex one, as you all know. I think all of us should know that the SDG 30 of the SDG 30, SDG 3 focuses on health. So when in relevance with the kidney care, Dr. Valerie Lakes, who is one of the speakers for the 8th March program with us, she's also the deputy chair for the ISN advocacy. She has done a lot of work of relevance of SDG 3 in relevance to the kidney care, and has suggested that the kidney care is a holistic one wherein we need just not the support of the healthcare teams, but also the roads and buildings and also the water departments, everything. So that was in lines with the availability, as you said, the availability of the clean water, sanitation, the accessibility, equity of the health services and all these things. So that's an important aspect of it. Apart from that, when you had quoted Dr. Ike Okapichi's paper 2022 KIR, I just recollected Dr. Ike is one of the salient persons who is involved with the GKHA, that is Global Kidney Health Atlas, wherein all the countries, out of 180 countries, 162 countries have participated in this GKHA. This is again an initiative by ASN, wherein the report was released in 2019, the second edition. The third edition report is an embargo. So what they have said is they identified the gaps, especially in all the countries, with relevance to the delivery of the kidney care. As you said, the focus was again in detecting the patients who are vulnerable to AKI, a targeted screening, and of course, in universal healthcare for the early stages of CKD too. In fact, it's, as you had rightly pointed out, our state is one of the best states which is performing with respect to the delivery of the ESKD services as a free dialysis and a free PD as well under the state as well as the central schemes. But then coming to the screening, I think though the pilot initiative was done, but I think it should be a sustainable one as far as the screening is concerned. So you screen them, you treat them so that you slow the progression of the CKD. Those are all the main targets for us. So we need to strengthen our services. We need to strengthen the policies and the frameworks that are in place, so that the CKD people are identified at an early stage, and the AKI people who are targeted at-risk people should be followed upon. This is where we find a little lapse. We know that the pre-eclampsia is such a huge burden wherein patients progress to CKD, but then what we lack is a robust follow-up of these patients. So obviously they'll end up in CKD, and then the burden continues. So I think certain frameworks and policy should come into picture for us to strengthen the follow-up of AKI and the early management of the CKD, so that our burden on the dialysis as well as the transplantation comes down. An excellent talk, an amazing talk, very good slides by you, Deepthi. Now over to you, the co-chairs, Dr. Rana and Dr. Rama. Over to you.
Rama? Yeah, that was a nice talk, Dr. Deepthi. You took us through screening. And yes, the high incidence, actually 16.4% you mentioned, the high incidence definitely mandate screening. So yes, that was another thing. Usmania was part of the ICKD study. So yes.
Yeah, good afternoon, everybody. I would like to highlight few points. As a full-time, I can say, rural nephrologist practicing in rural area, all those slides were very much relevant. And as we see, the census, 60% of the population of India are located in a rural and suburban area. And what you people are seeing, when I was also there in Hyderabad, we see cases which are referred, but majority of the, when we are here in rural and suburban area, we see the problem is really very, it's a real term, every day you're facing that problem. And 60% of the people are in a rural area are farmers. So the problem is genuine and it is real, it is massive. And when we see young people, if you do a survey of the dialysis unit in my unit itself, diabetes is not an issue. Only 30 to 40% of the patients are diabetic. The rest of the patients are like CKD, which is unidentified, hypertension and all that. And with younger people, I have written one paper also regarding this. Most of the patients are men. They belong to third, fourth, fifth decade of life, where again, we don't know what is the cause. They present with uncontrolled hypertension. And another study just recently done by a family student, she has done, in which we found that still in my unit, it's 5 years I'm working in the same unit. 70% of the patients still are not having control in the blood pressure. It is still 160, 170. In spite of maximum doses of drugs, again, compliance is definitely, non-compliance is a factor. So the thing should start quite early. The drugs don't work. The patients become more and more resistant to hypertension, develop complications of the hypertension. Other genuine things which you mentioned was the pesticide problem. Daily, 1 or 2 patients come with pesticide poisoning, and then there's a chronic exposure to pesticides also. So the awareness should start quite early by the policymakers, and also probably at the school level, how this farming practice has to be improved when 60% of the population are farmers. So what we are seeing is only a tip of the iceberg, I think. And other menace in this area is alternative medicine. We don't do the sweet talk. We don't sugarcoat our messages. The people, alternative medicine is a real, I can say, I use the word mafia, which is flourishing very well in these areas, where many people are involved in that. It's they run canteens, they run lodging boarding, and then they assure many good things. And once a patient goes into CKD stage 5, but the dialysis dependent state and becomes very bad, they dump the patient in government hospitals, like, and again from there the patients come to us. So these are real issues which have to be started at, as Dr. Manjusha said, that like a policymaker side. It is involving many industries. It is not only the healthcare industry, right, from farming to school to other industries. These are the 2 things. And I was thinking about the care of the vulnerable, that part which you addressed. I thought care of the vulnerable, I interpret it a different way. It is people who are like quite sick and all that. Are we ready to take care for them? I think in today's, so in the way we are going, care on the vulnerable is the onus is falling only on the family, not on the state or healthcare industry. So there should be a space and thinking for that care of the vulnerable. Some part of the responsibility should also be taken by us, which is, I think it doesn't exist now. It is completely falling on the family part. These are my comments, I think. And for the first talk was also very informative by Dr. Bhavya. Thank you very much. Yeah.
Thanks, Rana. I just would like to add another comment. As you rightly pointed out, the alternative medicine is just, of course, the poisonings we see immensely. We have about 200 in numbers right now, our registry as far as the paraquat is concerned. You also must be dealing with the same. But the other thing is the alternative medicine, which we know that the quacks give. And there's a lot of, literature, I don't say literature, some studies which have supported about the role of these alternative medicines with respect to the CKD. And this is much more practicing a multi-pronged approach of the healthcare. We have various other systems which are corollary to the allopathic. We see patients landing up in CKD, as you rightly pointed out, they land up in an emergency situation wherein it is difficult for us to, salvage the patient. And the other point that you said, supporting the vulnerable. Yes, supporting the vulnerable. Yes, the elderly, I think she has spoken about it. The pregnancy, of course, they're also vulnerable. But then the other aspect of it is the CKD 5D group in elderly, wherein again, a palliative care is the concept which is coming up, which we need to think about. That also is an entity wherein with the burden of CKD that is increasing and with the constraint of resources that we have, which we may have to increase exponentially more, it's a time and it's a need of the hour for us to think about the palliative care by the government, so that, people who think that after the shared decision making by the family, they think that the palliative care is suitable for their respective patients, that also needs to be brought into picture. Thanks, Rana. Thanks, Rama. And of course, thanks, Deepti, for that enlightening talk. Over to Dr. Kajri for further proceedings.
Thank you, ma'am. I would like to ask Dr. Rajshekhar sir to give few comments. I think he has some questions, sir.
Kajri, I just wanted to congratulate both the speakers. So much of learning, thank you. But the reason I raised my hand is both Rana and Dr. Manjusha mentioned about the care of the vulnerable. I believe strongly there is a need from the nephrology community to set up something like a small committee and look at geriatric nephrology as a subspecialty. You may be aware this Sparsh and other groups have done human service. I recently met somebody who had a transplant. The donor who donated the kidney 15 years back or 16 years back developed a malignancy and now needs palliative care. They were all praised for the Sparsh where they set up and a lot of work being done. I believe all of us have a reason to make a little more noise about geriatric nephrology, using these medications. I requested the board of WIN to look at it as a sub committee to take care and some action plan. I believe it's a very relevant thing to do for all of us. Thank you.
Thank you, sir. Thank you, Dr. Ashik Chakravarti. I think there's a very valid comments that you have made. Since that's a coming up one, I think we need to focus on that. We need to have an idea what is the prevalence and what the support can be given to the geriatric patients and what can be done from the government perspective as well. Thank you, sir. Thank you for that comment. Over to Kajal.
Yeah, just a second before Kajal takes over. So yeah, I would just like to chip in. Recently, I attended the palliative care conference and it was an eye-opener with the renal tract itself. And we have so many things which we can practice in palliative care. And I think that should be taken up. And definitely, I think at WIN level and government level, we will definitely try to do something about it. Oncology as of now is having that palliative care package in Arogyashri and in Ayushman, but other specialties are not utilizing it. And in fact, there are many things which can be taken up and we can have a palliative care package as well. Thank you.
Rajari?
Yes, ma'am. Thank you, ma'am.
Can you stop sharing
this was
screen?
a very interesting session indeed.
Can you just ask Deepti to stop sharing the screen?
Yes, ma'am. Yes, ma'am. It stopped. So it was a very interesting session as well. We got to know Dr. Deepti nicely navigated us through the targeted screening and screening of CKD, the high prevalence, the ICKD study, and also the risk of tropical infections, and also the importance of environmental pollutants. And also along with this, we also found new concepts from our chairpersons, like we have to identify the gaps still in nephrology, and we have to focus on geriatric nephrology, palliative care in nephrology. Well, it is a long way ahead. To keep this pulse going, we like to have a very interesting session of the panel discussion, and which will be on empowerment of kidney disease evaluation in the state of Telangana. That is, now we are moving on to a more practical and feasible approach which we can practice. And for this, I invite Dr. Priyadarshini John ma'am to moderate this session.
Thank you, Kajri. So after hearing some amazing talks and discussions about disaster preparedness, screening of the chronic kidney disease, and caring for the vulnerable, we now move on to discussion, more practical discussion, as in where does the state of Telangana per se stand with respect to the incidence and prevalence of kidney disease, and what are the various government and private strategies and schema in place to help people living with kidney disease, as well as to prevent the prevalence of kidney disease in the community. So for this, we have eminent nephrologists from both private and public sector. So for this discussion, may I now invite Dr. Anuradha Raman Madam. She's Senior Consultant Nephrologist and former Head Department of Nephrology, Osmania General Hospital. We have Dr. Gangadhar Taduri, who is Professor, Head Department of Nephrology at Nizam's Institute of Medical Sciences, and Dr. Ashik Chakravarti, who is Senior Consultant Nephrologist and Head Department of Nephrology at Yashoda Hospitals, High-Tech City, and Dr. Purva, who is Consultant Nephrologist at Virinchi Hospitals, Hyderabad. Thank you, sir and ma'am, for joining us for this discussion. So we shall start this discussion now. I would like to first ask Dr. Anuradha ma'am. Ma'am is one of the senior nephrologists in the country and the state. How do you see differences in the prevalence of kidney disease in the past and now? And do you think any prevailing research has promoted or helped in the early diagnosis of kidney disease when compared to the past? Ma'am, can you unmute? Anuradha ma'am, can you unmute yourself? Ma'am, we can't hear you. Can you unmute yourself?
Anuradha madam, you are muted, ma'am.
Okay, can you hear me now?
Yes, ma'am. Yes.
Yes, ma'am. Yes, ma'am.
Yeah, thank you, Priya, for this opportunity. And thanks, WIN Telangana, for this wonderful session that you have organized. Coming to your question, in my 40 years experience as a nephrologist, and probably as one of the first nephrologists of the state, have I seen a difference in the prevalence? I really do not know, because we do not have any statistics to show what was the prevalence then, because when we started nephrology, there was hardly any awareness of nephrology in the state. In fact, I remember we would not even do urea and creatinine, and forget about urine exam. There was hardly any awareness of kidney problems. So that leads you to think that we have absolutely no data on the prevalence. But we would certainly, when we see patients of CKD or think it is CKD, it is we who started this awareness of testing for urea and creatinine, which if you send today, the report would be available the next day. And even the electrolytes would be available only the next day. So we strived hard and had a lab of our own, a renal lab, where we could send these parameters from the OP itself and get the report the same day and then do the appropriate treatment. So I really cannot compare the prevalence of CKD at that time and at this point, but at this point in time, we know that even then, at that point, there were, at least in India, there were more younger patients afflicted with renal disease. And I think the same holds true even today. And there has been probably a slight shift, as shown by Professor Dr. Mani the first time when he said that chronic glomerular disease come next to chronic interstitial disease. So there he compared, and but probably we think that chronic glomerular disease is still common in this country. We had no IF, so we have never looked for IgA nephropathy. We just think of other glomerular diseases. So what is definitely striking is that we have more young patients, and that needs to be looked at, because we cannot afford to lose our young patients, especially who are in a socially active state of life, losing them to dialysis or losing them to CKD. So at this point, we have not done any analysis of prevalence data, but looking back at the analyzing our renal biopsies, which Dr. Swarnalatha was kind enough to give us data long back. I mean, this is about 6-7 years ago, almost more than 5,000 biopsies reported by a single pathologist in Hyderabad. We have shown that, and obviously, this is a skewed analysis because we do not biopsy most of the interstitial diseases, and we only biopsy the glomerular diseases. We do not biopsy routine diabetic nephropathies unless we are suspecting a non-diabetic renal disease. So although this data is skewed, probably chronic glomerular nephritis in that series was the commonest cause, as probably is even in the present.
Thank you, ma'am. Yeah, ma'am, please go ahead.
No, the second part of the question that you asked me.
Yeah, do you think any role of research, as we have advanced much when compared to the past, helped in the early diagnosis of chronic kidney disease?
Oh, yes, there has been a lot of improvement in terms of research. And one of the most exciting fields is genetics, especially in glomerular diseases like focal segmental or hereditary disorders. We have definitely now, we have access to genetic screening, and that will help us not only to diagnose these conditions, but how we should counsel them regarding future transplant. HUS for that matter, HUS, various FSGS, and other inherited disorders. Genetics has certainly played a big role, is still playing a big role in, and we have certain biomarkers now, which have helped us to do away with biopsy, which is an invasive procedure, especially in Plato or positive membranous nephropathy, where we can initiate treatment even without biopsy. So these are some advancements that I see from then to now. those days we used to use that Franklin's modification of Wim Silverman needle, which was very scary. But now we have a gun and we do it under ultrasound guidance. So that makes a lot of difference in managing our patients.
Thank you, ma'am. Agree on that, genetics and biomarkers have helped us a lot in management as well as in the diagnosis of chronic kidney disease. And I think when it comes to statistics, we are now taking up, trying to take up the registries of various kidney disorders, even under the leadership of Dr. Manisha Sahai. So I think we would definitely have better statistics and all in understanding the prevalence of kidney disease, and in future probably this will definitely help us to find out where exactly we stand and what are we supposed to do to mitigate this kidney disease in the community.
First, one word, Priya, that I was a part of that CKD registry that Dr. Mohan Rajapurkar started, and in that analysis also, diabetic nephropathy stands out as the commonest cause of CKD in our country, followed by glomerular diseases, followed by interstitial diseases. Again, we do not have biopsy-proven data. These are purely what the nephrologist felt at that point, and that's where we are today.
Yes, ma'am. Thank you, ma'am. Dr. Gangadhar sir, we know that you did a lot of work on CKD-U. So apart from the conventional risk factors and the non-communicable diseases, how much is CKD-U contributing to the burden of kidney disease in the community? Dr. Gangadhar?
I think Dr. Gangadhar sir is on phone. Can you please pass on to the next question?
Dr. Rashika Chakravarti sir, I would like to ask this question to you. So heading one of the busiest corporate nephrology sector, do you think there is a difference in the nephrology burden in private sector? And what do you think are the cost-effective strategies in private setup to mitigate the chronic kidney disease prevalence?
So that's a very interesting question, Priya. Dr. Andada clearly told about the prevalence in the ester years, and now probably not increasing, but we are more proactive in picking it up. Let me start answering the question, just sharing with you. We started something called as a Care for Your Kidney Foundation. Many of you may be aware in 2015. So it is an NGO headed by Mr. Narendra, who is the chairman of Pragati Quinter. In the last 7 years or so, we have screened 10,000 people in the urban slums of Hyderabad. Every Wednesday, one doctor from the foundation used to go, and inspired by Dr. Mani's work, we did it. So close to 10,000 screenings, the prevalence of CKD we found by definition 14.8% in the urban slums. This was presented in WCN, and Dr. Santosh, who is in care now, HEDAYU, he presented it. So if you look at that burden and then look at the corporate and the government, I believe prevalence-wise, there won't be much of a difference, either government or private sectors. But the type of diseases that we see will definitely be very different. So the glomerulonephritis burden that a nephrologist practicing in private hospital sees will be little less, I believe. And we will see more of diabetic kidney disease, cardiorenal syndrome. In fact, one of the things that is very different from in the corporate sector is a lot of multi-organ involvement. Somebody has a cardiac disease, somebody has a renal disease, and each one will drive the other one. And they progress very fast. I have found that cardiorenal syndrome progresses fastest, even faster than diabetic nephropathy. So there are definitely differences in what we see, but I think prevalence-wise, all of us are exposed to the same. How do we prevent? I believe the private hospitals do have the wherewithal. You may be aware, we started estimating GFR in 2002 when Dr. Sita Devi was the chief of biochemistry in care. The first time we validated it in 54 patients, where we did a isotope renogram in all 54, and we did a Cockcroft galt and we did the EGFR at that time, MDRD, which was being used. So I believe corporate hospitals can definitely do a little more in the community. I believe each one of us should set aside some time and money from the hospital to do screening in and around the hospital itself. So I've been pushing managements in all the 3 places I worked to start one division of community nephrology. We should be able to look at EGFRs, and in the presence of proteinuria or high blood pressures, then any structural abnormalities, giving a label to patients and saying you are in CKD 1 or CKD 2. If you don't do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, it will progress over a period of time. It goes a long way in making them adhere to your plan. That has been my experience. I actually write down many times and tell them, you are in this label. If you don't do these things, a list of 10 do's and don'ts, and then you will progress if you don't do. I believe that will help a lot in delaying the progression.
Thank you, sir. Thank you so much. Dr. Gangadhar sir, I would like to ask you this. We know you did a lot of work on CKDU. So apart from the conventional risk factors, how much do you think CKDU is contributing to the burden of kidney disease in the community?
Yeah, actually, it's a good question. The continuation of Dr. Rashekar sir was mentioning about the burden. Actually, government of Telangana, we started on totally profiling the health profile of the population. We have completed 2 districts actually, like Mulugu and Sirsilla, where in Sirsilla we screened around 5 lakh population, and Mulugu we screened around 3 lakh population. So there the burden appears to be around Sirsilla around 6.5% of the persons who screened, they had a kidney problem with the creatinine. We've taken the creatinine and as a marker. And the Mulugu district, where we screened 3 lakh population, there appears to be 5%. So apparently the the prevalence will vary from region to region, but apparently the overall state appears to be 5 to 6% of the population which screened are having kidney disease. But if at all we look at the at-risk population, the prevalence will increase to 11% and 14%. At risk means those are diabetic, hypertensives, and they're having other comorbid conditions. In the prevalence in them will increase. And among this prevalence, what is the contribution of the CKDU is an issue. Like classical teaching is the diabetic and hypertensives are the major reasons for the CKD etiology. But in the rural villages where the diagnosis of the CKD itself is delayed, by the time we diagnose them, they're already having a shrunken kidneys and creatinine is around 2 and 3, urine abnormalities will not be there. So at that time, we try to club them into a etiology of CKDU etiology. If at all they are fitting into the criteria, we are calling it a CKDU. So definitely this is contributing to around 30 to 40% of the population who are having kidney disease in the rural population. In urban also, I think the major drivers are diabetes and hypertension. And the CKDU is not prevalent in one location. Though we have done some studies in initially starting with Nellore, then we went to Prakasham, we went to Srikakulam, but it is also now reported in the majority of the states in our country, like Tamil Nadu is also reporting, and West Bengal is reporting, Orissa is reporting, Punjab is reporting, Goa is reporting. Apart from that, actually the worldwide has also the prevalence is increased, like Mexico and other countries also, they're reporting CKDU. It is actually a multifactorial in nature, where drivers are, we also published papers on heat stress is the etiology for that driving the CKDU etiology. Heat stress is one, and adequate hydration is not there. More painkillers are being used. They're exposed to the heat stress. So these are the common factors which are driving the CKDU in the public. So how to prevent is a major issue. Apart from that, what we talked about the prevalence. So prevention is the best thing until unless you screen that and try to address which are the drivers of the kidney disease, and try to address the risk factors where you can remove the risk factors and avoid this kidney problem. And the second thing is identification of the early disease so that we can intervene early and we can prevent the progression of the disease. So among this, so a gross macro level, how to prevent the diseases, actually what we advocated is supplying the surface water in these regions. The surface water, because the groundwater was containing a lot of elements like silica was there, strontium was there, and these are the problems which are causing the driving of the kidney disease. So we were at most successful in eliminating the groundwater in Srikakulam. They're having a surface water supply now. Ongole, they're having surface water supply now. Nellore also they're having surface water supply now. And in Telangana, as you know, Mission Kakatiya is there, where every household will get a surface water, piped water supply for all the households. So this is the way where we can do a community level or a government level intervention to prevent the kidney disease at large. Second thing is actually orienting the public health system for identifying the disease and treating them early. So like in primary health center, we have ASHA workers, we have ANMs, we have staff nurses, we have medical officers, where we need to have some training for them to identify the disease early and treat early. So that also should be done. And right now we are trying to do in coming 8th March, that is a Women's Day. Actually, government is trying to start. I am happy to inform all the Win India group that actually Telangana government has taken a decision to start women health clinics in all the primary health centers. Like every Tuesday of the week will be dedicated to the women health, and also in all the referral hospital like district hospital and teaching hospitals, we have a kiosk or a corner where women health corner is there. So all the priority will be given to the women health, because as we felt actually the women are health seeking behavior is less, and whenever they go to any health center, access is a problem for them. So the government has thought over it and planned for a women health initiative. In 8th March, I think we are going to start this program where 8 pillars are there. 8th March, 8 pillars are there. In one pillar will be screening for non-communicable disease. In that, kidney disease is also involved. So we are trying to screen. Why I'm trying to tell you, the screening is also one of the important factors where we can intervene early. So this is one factor where we can intervene early and identify early and treat them early. And providing the medicines, because they're all long-term medicines like diabetes and hypertension. So there is a vertical program for treating them also, like providing the monthly medicine for diabetes and hypertension is also underway. We have created a kit, NCD kit kind of a thing, where the patient coming to the health facilities will be given a kit which will contain diabetes and hypertension medications, which will be given for a month. So what happening in the past is actually they are giving for a few days. Whenever you go to health facility, BP and sugar medicines are given. Only few days after that, they'll not take. So to avoid that, we are trying to give a package, like a 1 month medicines will be given. So all these measures, like one is the grassroots level, we are trying to address which are the drivers of the problem, like supplying a good water and trying to have the food chain also. That is also important thing, where if at all food chain is also not good, like cutting down the salt, cutting down the fats. So all these also drivers of the NCDs that also we are trying to address in the government level, so that actually the burden of NCD itself will come down, like diabetes, hypertension, where thereby kidney disease will come down. Other etiologies, your CKDU, where water, environment is playing a role, where we should try to address that. So overall, if at all we address all these factors, the prevalence of kidney disease will come down. Otherwise, the expenditure on kidney disease management is increasing. Just I want to share the fact that actually we are spending, government is spending more than 100 crores of rupees only on dialysis per year. We are funding more than 10,000 patients, both government and private sector. This is seeing around 5 to 10% escalation every year. Every year we are finding 3,000 patients entering into dialysis program. So this we should be able to cut down in the long term with efforts of both government and private sector, trying to cut down this burden of the disease which is happening in the community. I think there's a long way to go, but we should start with a firm step with a good foundation. If our foundation is good, definitely the results will be good. So screening is happening in the community level, number one. Training of the people, understanding the interpretation of the results is also happening. Trying to giving the medicines free of cost for all the people, that is also happening. In the long term, I think we'll definitely yield a good result in the long term. Thank you.
Thank you so much, sir. It's very glad to hear what all government of Telangana is doing to help people of our state live with the kidney disease. We know about hub and spoke model. That is really a boon and blessing to all our dialysis patients, which helped patients cut down their travel cost to travel all the way to only Usmania Gandhi NIMS previously as it was. Now they can cater their dialysis needs at the nearest place possible. Thank you, sir. Now I ask this question to Dr. Purva. It's distressing to see younger age group landing in renal failure. We see a lot of young people landing in chronic kidney disease and progressing to kidney failure. So what, according to you, are the probable reasons for these young patients queuing up for dialysis and chronic kidney disease?
Yeah, it is very disturbing to come across young patients with kidney disease requiring dialysis. In fact, to clarify what is young is the United Nations defines young as the population between 15 to 24 years. So if we look at that, the numbers in this population requiring dialysis are increasing at an alarming rate. And I think the most common cause remains to be lifestyle disorders, that is diabetes and hypertension. But apart from that, as Sir said, CKD of unknown origin, probably due to various factors like environmental hazards, heat fluctuation, inadequate hydration status, painkiller use, and even congenital abnormalities that continue to kidney disease are the causes that cause dialysis in the young population. Now, as far as the preventive strategies are concerned, there has been a very elaborate discussion about the same. So I would just keep it short. Preventive strategies need to be at a very holistic and multiple levels. In fact, that early detection of diabetes, it has already been discussed in our forum today, but nonetheless, early detection of diabetes, hypertension, and their control is very essential. One new thing that I've learned is that educating the masses right from the childhood regarding the importance of staying hydrated, a good diet, and lifestyle is very important. When we empower children and youngsters and make them aware of early signs of illness. Hello? Yeah, am I?
Yeah, you're audible.
Hello? Yeah, I'm sorry. Yeah, so if we, it's also very important that we make the youngsters aware of early signs of illness and we catch hold of them when the injury is reversible. Another important factor is that we should inculcate habits in this population, especially to adopt eco-friendly methods because environment plays a very important role. Although it is silent, we may not see the effects immediately, but the long-term impact on health is evident with the recent calamities that we are seeing. And World Kidney Day is, of course, focusing on those issues as well. Lastly, what I feel is this month, it is World Kidney Day, but the whole month is being celebrated as the Kidney Month. Several healthcare professionals are coming on various platforms, which itself is a very, it's a great initiative, and it itself is a preventive strategy to mitigate dialysis in young. Voice.
John, you have to unmute, John. We are not able to hear you.
Yeah. Thank you, Dr. Purva. Thank you so much. I would like to ask this question to Dr. Rajshekar Chakravarti. Sir, how can we integrate kidney health to the patient care right from the primary care physician? How do you think we can get early referrals so that we can see patients in early chronic kidney disease?
So again, a very interesting question, Priya. Most of us will be interacting with a huge group of physicians, and over the years, I came into Hyderabad in 2002. Now it is 20 years. I found that the physicians do send patients as early as stage 2, especially if there is something in the urine like protein and the active sediment. I think the best way is every few months, either from Telangana or the AP or Telangana state group, we have to talk to physicians. It could be once in 6 months on a theme like just you did now. Invite them. I find them extremely receptive to what we give as a list of things to do when they see the patient the first time. Whether I go to Bangalore or anywhere else in the country, some of them are extremely interested. I think as a platform, we should create some more interaction between them. The minute you see a patient sent from them, send the patient back to them with a recommendation, preferably writing it on paper. It does help them to do what you want them to do. And they also keep sending the patient back to you once in 4 months or 6 months as you would want to follow. That has been my experience, and most physicians are very, very receptive to this much of interaction.
Thank you, sir. Thank you so much. Dr. Anuradha ma'am, how can we raise awareness of kidney disease in the community, as well as how can we raise the importance of organ donation in the community? Ma'am, can you unmute yourself, ma'am?
Yeah, I fully echo what Dr. Chakravarti has said. We have to catch them when they are being treated by the general care physicians. And we know now KDIGO has made it very clear that especially when they have, we should educate the public through various media. Now you have social media also on how to detect renal involvement, especially in diabetes, a simple urine exam, and when they should refer to nephrologist. When there is heavy proteinuria, that's the stage, whatever the level of creatinine, they should be referred. And also, what is the importance, especially one family member has a renal disease, it becomes imperative that others, family members should be screened for renal disease. I know this has social implications, but nevertheless, if we really want to help the community at large, we need to focus on this and tell them that at least we can take preventive strategies, emphasize on the diet, because most of the patients, when we say salt restriction, they totally restrict everything and they become malnourished. So the importance of salt restriction, not taking alternate forms of salt which are high in potassium, not taking alternative medicines like Ayurvedic which contain metals, not taking too many NSAIDs, and of course of late not taking even PPIs, because even PPIs are supposed to have been documented to cause renal failure. So all these, and if they have any problem, immediately come to the medical aid. And more important, since all of them will go, especially in India, all of them will have some primary care physician treating them. So as Chakravarti says, I think we should target that group, have CMEs, and they are really receptive. They come, they attend, and they want to learn. So I think that's the way we can really create awareness, not only among the, among the public, indirectly through the primary care physicians. And your next question was about renal transplant?
Organ donation in the community, ma'am.
Organ donation, well, again, this is through various activities which Win India and also the transplant team as a whole is doing. You need to educate the public on kidney donation, have coordinators, teaching sessions, have some workshops, and then tell them that kidney donation is not harmful. We take all precautions, we keep them on follow-up, and then encourage them to do live donation. And if it is cadaver, now that it is picking up so fast in our part of the state, the only way is to make the public aware that by doing a kidney donation, they are going to help or save 7 lives. And of course, that no religion says that kidney donation is bad. So I think we need to have constant teaching sessions for the public and for the primary care physicians and all public mostly. And of course, donor card. We again and again should emphasize on the donor card and how they can register themselves for kidney donation. Priya?
Thank you, ma'am. Sir, Dr. Gangadhar, sir, I would like to ask you, what is the level of disaster preparedness from the government of Telangana with respect to any disaster, taking COVID into consideration?
So disaster management, actually the COVID was a disaster. Actually, we managed very well in the terms of offering dialysis to the population. And in fact, the hub and spoke model, which government has initiated, helped a lot because they were decentralized like Utnur and Kottagudem and a lot of other interior parts of the Adilabad. There also dialysis centers were established. When the COVID happened, where the transport was totally shut down, because of this hub and spoke model, the spokes were there. Patients were able to, the dialysis services were never stopped during the COVID time. That's an achievement actually, because the decentralized model of dialysis was there, 48 centers were there, and we were able to do the dialysis at their level, and we are doing the tele-dialysis services also. I think we are giving tele-consultations to them. So that's how the disaster, at least the recent disaster, was handled. But other disaster management preparedness is an important question where we need to prepare ourselves is the importing of disposables. That's a major issue. The chunk of the hemodialysis machines are coming from outside. Dialyzers, actually dialyzer tubings and RO plant. A lot of companies are coming now where they're trying to manufacture the dialyzers here, tubings here, and the transducer protector. Other disposable are being manufactured in India, Make in India program, and also in Telangana, also few companies are trying to come up, because this is also important as a management of disaster preparedness. If at all war is broken, where all the services are stopped, embargo is there, like in Ukraine, what is happening, the dialysis services are disrupted, the medications also, because of being a pharma hub of the country, our Hyderabad was able to have medication for COVID and vaccines for COVID, and the antihypertensive medication, a lot of other medications also. At that time, we planned such a way that actually we were able to supply through the government to the majority of the patients who are getting this sort of a program. In fact, one more measure that from the government side, what we have done at the time was, instead of giving monthly medicines, we are given 3 months medicines during the COVID time. At that time, I think Dr. Manjusha and Dr. Manisha remembers, we had a meeting where at least government sector hospitals where the patient got a transplant, we couriered these transplant medications to the patients. So disaster management, definitely our country should have a policy, basically having a manufacturing facility of equipment and consumable. These two things, if at all we are self-sufficient or self-reliant, definitely we can make up in any disaster. We didn't have any problem during the COVID time for disposables, like dialyzers available and tubings were available, because the manufacturing was there in India. Machines, okay. Machines also not manufacturing was there. Machines, existing machines were able to cope up. But imagine that actually we are trying to import everything from the Western countries or in other countries for the dialyzer and disposables. Definitely, COVID could have been hit as a hard way. But this strategy need to be developed for dealing with disasters. These are actually the one disaster. Other disaster is actually you have earthquakes and all those things. That is the other disaster where a preparedness plan should be there, where we should be able to establish a dialysis center at that site where the communication is cut off. We should be able to establish a dialysis center there. That disaster preparedness, as of now, we didn't have anything on place. But definitely anything, that sort of a thing is there. We should be able to establish a center by shifting the machines, portable RO plants, sufficient water supply should be there. That also need to be discussed and planned. So the disaster management plan was, for COVID was discussed extensively. We implemented it and we succeeded in that. The other disasters also like wars and also other areas, the government of India is readily prepared where they're trying to promote Make in India program. In that, all the things are manufactured in our country, and in fact, our state also. So that's all for managing a disaster from my point of view. Yeah.
Thank you, sir. Before we end this discussion, I would like to ask a last question to Dr. Rajshekar Chakravarti. Sir, as you are in a private practice, I think you have, do you think the private sector is edged with better preparedness for disasters and any man-made and natural disasters?
The simple answer to that question is no. I believe both of us, whoever is in the government setup, especially in our state, they have a wherewithal to do most of the things. Having said that, I am aware International Society under Van Holder had a subcommittee on disaster management. When there was a disaster, they would send a group of nephrologists there and technicians there and set up units and dialyze. One of the things I strongly believe we should do is, among the younger colleagues, some more insights into peritoneal dialysis as a modality. I find that many of us do not know how to manage patients on PD because over a period of time we have not learned that art. So again, Telangana State Forum should help us to disseminate this knowledge. Peritoneal dialysis is one thing, probably can be done and set up, as you know, anywhere, anytime. We just need the disposables and a catheter. This is one. Second thing, we need to have an agreed protocol. Dr. Bhavya did a great job of telling us how to manage. I believe initial years there was some controversy about mannitol versus only saline. As soon as you get one arm, at least from the rubble, you put a IV line and start saline. So hydration and others. We need to agree upon a protocol in the case that there is an event, what all of us should be talking the same language. These two things, I think, will go a long way to manage it, whether it is the government setup or the private setup.
Thank you, sir. Thank you so much. I think we have miles to go before we give the best patient care and affordable care to all our patients in the state of Telangana. And I hope that we all work together for the betterment of the patient. Thank you. Over to Kashri.
Yeah, I mean, before Kajri takes over, can I just step in and say a comment? Because I think Telangana, Dr. Gangadhar, if you remember, there was a natural disaster, the whole Adilabad, because we had patients from Bhadrachalam and Kottagudem and all this. The whole Adilabad area was leashed with heavy rains, at which time, it was very surprising that we did not have any challenge that was faced by any of the patients because of the dialysis centers that were developed over there. Though Telangana is not much prone for the natural disaster, but this was one recent natural disaster that we had. This is about 8 months back. The Adilabad areas, Bhadrachalam, were inundated. The technical staff as well as the dialysis had little challenge in traveling and all these things, commuting to that particular areas, and it was in fact there for about 10 to 12 days or something like that. But we never had, those areas are under our hub. We never had a complaint that the patients missed dialysis or the patients came to us in an emergency or there was a mortality. Nothing like that. So I think that was one of the very well managements that was done, though it was not an instantaneous management, though the built-in system had answered the whole natural disaster. I think maybe your comments on this, Dr. Gangadhar.
Yeah, actually the decentralized fashion of establishing dialysis centers and having a storage of the disposable there definitely helped, because each year we have this sort of a natural heavy rains in especially in few centers, like I'm not saying all the centers, but few centers like Etur Nagaram, where the heavy rains will cause the flooding and the cutoff will be there for some time. But at that time, what we have done is actually we stepped up the supplies and the supplies, because Hyderabad was a hub where the entire storage of the disposable were there, dialyzer tubing and other things. We are trying to put more storage there and we are able to manage that. So other times the access is not a big issue, but only few locations of dialysis there, this problem is there, then definitely we need to address like that. But apart from that, actually patient travel also, apart from the dialysis, the patients who are coming from the interior parts, there also the cutoff will be there. That also we need to address. But I agree with Dr. Rashekar for promoting the PD in these locations, but some challenges are there where we need to address to. And I am also seeing Rana Fatima commenting about peri-PD in Arogyasri also. This we need to take a call because the cost is a constraint here. Dialysis is 50% of the cost of the CAPD. So as a forum, if at all we are able to convince the vendors for coming down the cost, and we are able to produce the fluids in our own state or our own country, bring down the cost, definitely we can give an option. Because the convincing the government for a higher, double the procedure what we are doing, can be done as for selected patients, like in Gandhi and Usmania, the government is funding the PD program also. But the other sector, we are not able to fund, basically because of the cost constraint. But selected patients, like patients who are having a problem with access or pediatric patients, we can, as a forum, we can have a discussion and we can request the government for funding this PD also. Thank you.
Dr. Gangadhar, just thank you for your comments. And I just wanted, the discussion earlier, we had discussed about palliative care also. So nephro-palliative care packages, that is one package, and CKD screening package under Arogyashri. I mean, just mind for somewhere future implementation. That would be other two firsts for the government of Telangana, and really appreciate the schemes of government. They have been helping our patients. So thank you very much.
Thank you, Dr. Manisha and Dr. Manjusha and Dr. Swanlata. They were in the, and Dr. Bhushan and other government sector nephrologists were in the committee to decide the packages.
Dr. Kiranmai also, Gangadhar.
Yeah, all the people. That's what all the nephrologists are in the committee to decide regarding the packages under Arogyashri. Definitely, we'll try to put forward these recommendations to the government, and we'll try to offer a better care to the kidney patients across the state. Kidney patient now getting free dialysis, free bus pass, pension is there. Free transplant is there, free lifelong medicines are there, free screening is there, everything possible, whatever it is there, we can push it. One thing that we are trying, but we are not successfully, is to put this kidney disease into the Act, Right to Person with Disabilities Act is there, RPWD, where the hemophilia and the sickle cell anemia were recently included. But at the Parliament Act, if at all we are able to include this chronic kidney disease, because patients are living with disability. If at all Government of India identifies this as a disability, definitely the other benefits like education, institutional reservation will come, job reservations also will come. So I think as a group, both Win India Group, ISN Group, we should be able to bat with the Government of India to include the kidney disease, chronic kidney disease patients who are living with disability into the list of the diseases. Like we have 19 diseases are there in the disability list, where recently hematologists were successful in including the hemophilia 1, sickle cell anemia, and thalassemia. 3 disorders were included. Chronic kidney disease also we tried, but we are not able to include them into the list. If at all we are able to do, we will be helping more patients because they are living longer. They need to get into schools, they need to get into jobs. They should lead a normal life while they are on renal replacement therapy. I think as a group, we should be able to convince the governments to do that. That's my last comment. Thank you.
Can I chip in, sir? I'm from Usmania. I'm Dr. Anuradha. Sir, we are seeing many pediatric cases with chronic kidney disease. Most of them lose their school. So it is very important to have a vocational training or some kind of a special education for these children, sir, because they live for a longer period of time with chronic kidney disease. They miss the classes in between. So it is always better to have with the normal education, special vocational training, which wherein they can contribute to the society. At the same time, they can have this accomplished feeling. That is what I feel.
That's a good suggestion. If at all we give a proposal, definitely we can take up with the government because the other children like disabilities, definitely they have a different schooling for them. This also we can include into that, but we need to develop a proposal and get to the government. Definitely we can take it up. Thank you for a good suggestion.
Thank you, panelists. It was a very enlightening and comprehensive panel discussion indeed, and it is very glad to know that government is with us in every aspects, that in terms of screening or new packages or opening of women health clinic, and also there are disaster preparedness plan is underway, and in total that we are not underprepared, we are somewhat prepared. So to bring this wonderful session, panel discussion to a close, I would now request Nephrology, Usmania Medical College and Hospital, to give her concluding in today's session. Thank you, ma'am. Over to you, ma'am.
Yeah. Thank you, Kajari. We have been quite instrumental in carrying forward the campaign of 2023 World Kidney Disease Theme, that is preparing for the unexpected and supporting the vulnerable through these wonderful talks. So this campaign is going to focus on raising awareness about disaster events and mitigate the impact on people living with kidney diseases, so that the services are not interrupted and they are not jeopardized during these testing times. And it is the contribution from the policymakers, governments, healthcare services, and indeed the patient education and empowerment and general population education and empowerment, which helps in emergency preparedness. And first and foremost, I would like to thank the WIN Telangana chapter for organizing this wonderful program. And furthermore, I would like to express my appreciations for the speakers, Dr. Bhavya, Dr. Deepthi, and the panelists, Dr. Anuradha Madam, who is the senior most nephrologist, who was seen in the both sides of the spectrum, both in the government and the corporate sector, Dr. Rajshekhar Chakravarti sir, and Dr. Gangadhar sir. And thank you, panelists, for your valuable contribution to the WIN Telangana state chapter panel as a part of a World Kidney Day celebration. And my deepest gratitude goes to all who have participated and contributed to the program and helped to make this event such a successful event. Thank you.
Thank you, madam, for your kind comments. We think we are going to conclude the session. And it was a wonderful session initiated by the welcome address, then followed by very relevant topic discussion over AKI, CKD, and then followed by a very enlightening panel discussion where we learn about new government strategies, the hub and spoke model, and also the disaster preparedness plan, which is underway. And it's very relieving that we are also prepared, whatever may come. And to conclude, we can say that the teamwork always make a dream work. So we should all work together for a better kidney, to save more kidneys and more nephrons. And thank you. I thank WIN Telangana chapter for organizing this wonderful session and the organizing committee. Any other questions or comments are invited. Otherwise, we'll close the session. Hello.
Thank you. It was a wonderful session. We'll conclude this session.
Good. Thank you and a very happy Sunday. Good day to all.
Thank you.
Thanks, Kajuri, for nicely hosting the session. Thank you.
Thank you.